Thank you very much indeed, Jane, for this introduction. I don't know what to say.
Nothing.
My topic is, following that introduction, taking cardiac surgery to the people. And in this talk, I will try and show you the size of the problem. And to paraphrase Jane Somover, who used to say about adult congenital cardiac surgery, who cares, who acts, who pays? And so I'm paraphrasing Jane to say, who cares, who acts, who pays? And before that, I'm going to talk about case of need. Do we really need that as cardiac surgeons and cardiologists worldwide? And who are the stakeholders? And most importantly, if we talk about stakeholders, we have to talk about sustainability. The stakeholders should be chosen to actually have this as a sustainable effect. And again, to paraphrase one of the great surgeons whom Jane knows as well, Aldo Castaneda, we used to talk about surgical tourism. By that he meant that many of us, and I have to admit to be guilty at the beginning of my career, to be guilty of surgical tourism, like going for a week to South America or somewhere, operating on 10 patients, coming back, only to hear that 9 out of the 10 has died, or Africa or somewhere. So this really cannot be the case when we have to think about sustainability. After a long experience and a lot of thinking, our group and many others have come to the idea and the concept of a dedicated cardiac center as the answer. And importantly, integrated training, because human resources are just as important, maybe much more important than physical facilities. It's human resources which is important. And again, as Aldo and many others have shown, that you cannot offer a service which is less than optimum. It has to be at the highest level, and therefore there should be built into it a quality control. And then the last thing, research, because this has to be integrated in the concept of a dedicated cardiac center, because the concept, even in first world, if you like, or high income, because low and middle income is a better term than third world and first world. And people think of research as a luxury. This cannot be. And from day one, in all centers around the world, research should be an integral part of patient care. And I would show you why. I'm sure all of you believe that too. And then I will end up by showing examples. Now, what is the size of the problem? Well, cardiovascular disease, and you all know that, in this talk might be more appropriate to a general audience, is the leading cause of death and disability worldwide. And statistics show that even starting 2008, there were 17.8 million deaths in 1 year, and 80 deaths from cardiovascular disease worldwide, This is increasing with the cardiovascular epidemic. 80% of the burden of disease, as shown in many studies, is borne by low and middle income countries. So this cannot go on. You can go on to see that also the death and disability in the developing or in the low and middle income countries is borne more by children. And many of these conditions are preventable. Now people think that it's all to do with risk factors. And only 2 weeks ago, there was an excellent study, first author Salim Youssef in New England Journal of Medicine, showing paradoxical results. What did it show? It showed that while risks for cardiovascular disease are increasing in the high-income countries, but mortality is going down. So there isn't the link we thought it was, that mortality is related to only risk. And there is some of that, of course, that you need to apply prevention. But the only explanation for that is that actually different types of tertiary care in high-income countries are responsible for the observed diminution in death and disability in the developed world. To give you an example of the massive inequalities which is continuing around the world, and childhood annual mortality was 152.5 per thousand in Guinea-Bissau versus 2.5 in Singapore only last year, 2013. We're not talking about the past. We're talking about the present. This massive inequality, which can be up to 50-fold, is just something which shows that the size of the problem is huge and cannot be tolerated by any means. Then about who cares, who acts, and who pays. You could argue that who cares? Of course everybody has to care. Every human being on planet Earth should care. But who should act? I submit it has to start from cardiac professionals. Why? Because they see the suffering firsthand, so they know what's going on, both in the developed countries, but also when they go abroad. They have access to international networks. They meet around the world like we are now. They talk to each other. So these networks are capable of delivering a whole lot of things, and it is starting anyway. And importantly, that they can start acting in small groups and achieve initial quick wins. That is essential because it demonstrates that it is feasible and it should have sustained the effort, like I mentioned before. Then comes the big problem: who pays? Where are you going to get the money from? And you don't need massive amount of money initially anyway, and you do not and cannot go to huge organizations to start with. To the WHO, they have no money. You can't go to big donors because they believe, up till very recently, that it is not worth it to invest in cardiac surgery. It's too expensive. I presented my data, my ideas once in Rome to Médecins Sans Frontières, and they thought that this was just untenable and it's really an expensive form of treatment which will not have an effect on the whole picture. So you have to start and depend on yourself. And experience has shown that many small donors can do a lot. And I'll show you that later in this talk. So where do we start? We have to choose a site. And how do we choose a site? I just told you, the case of need. And it's relatively easy. So you go to a place like Ethiopia, 85 million. How many cardiac centers? 0. So that's so obvious that Ethiopia has to be a site. The same applies to Burundi. There are certain areas in middle or low-income countries like Egypt, where I originally come from, like the south of Egypt, they're totally neglected. So you can choose an area where you see a massive need based on numbers. And then you have to think about the idea of a dedicated center. Now, to serve a specified population in areas like Ethiopia, as I mentioned, 85 million is not, so you are having one center per 85 million. Some time ago, I was part of a task force from the WHO to determine the need for cardiac surgery per population. And we convened a meeting, one of my colleagues from Sweden and myself, in The Hague. And we had a panel of 15 people. And we came up with some figures. That was some time ago, but I think the figures hold. That there should be at least one center per 3 million people for adult for pediatric cardiac surgery, and one per million for adult cardiac surgery. And if you look, I have figures to show that, I've just told you, that in certain parts of Africa, there is none for many million. So that gives you just a rough estimate or just idea of where and how you can start these centers. Who are the potential stakeholders in this system I'm proposing to you? I believe it has to start by professionals. And when I talk about professionals, I mean cardiologists, cardiac surgeons, nurses, administrators, and a small nucleus. They are the initial stakeholders. But then they should find what we call a correspondent in the country where we're going, who thinks the same and will start the effort. And then publicize that to the people and tell the people, the population, in no uncertain terms, that all this effort belongs to them and they should be stakeholders. You have noticed I haven't talked about governments, and that's for a simple reason, because governments are poor. They are there interested in their own power and re-election. They talk about the people, but really they are almost, they are interested, not completely uninterested, but they haven't got the means. And the intelligent ones tell you so, that we will help you, but we have no money, and we have no system for insurance or anything else. So you say, okay, we'll just, you can be with us, but we don't expect any money from you. You can use existing links, of which, as I mentioned earlier, there are many. As I talked before, you need a reliable correspondent who thinks the same, and that's not too difficult. There are many people who see the suffering of their own people and want to help in that direction. And most important, you must ensure that the population are supporting this venture and they are enthusiastic, because many times I have witnessed that they say, oh, you're coming to exploit us again. We have suffered from imperialism, and people come here to collect money and experiment on us. And you have to break down that barrier and say, I'm not here to collect money, and I'm not here to experiment on you. We are here to actually genuinely help you, because we are professionals, and that's our job. It is not a charity, as people say. It is a duty, and we're doing what we should do as professionals. I mentioned about the government and its involvement already. The stakeholders, I mentioned that the populations must know for sure that they own the venture. We're here for them, and not only that, we're not going to be there forever, and they have to, this is going to be a sustainable effort, and they will have to inherit it in toto, and that also applies for the workers. We should choose young, enthusiastic professionals, and it's not difficult. They are there in every country. A very important element we have learned through the year is a strong, transparent administration. And we have been blessed in Aswan, for example, by such people who really help us to run the system in a very professional way, without wastage or with minimal wastage. And they help us to all guarantee sustainability. How do we guarantee sustainability? Actually, by training people, that's very important, and they can carry the load. But also they need funding. And how can you do that in the longer term? And I will show you examples. I mean, you can be spending several millions in one center every year. How is that going to go on for the next 100 years? Difficult. But there are ways, and endowment is one of them. Many business people know that they want to support something which is sustainable through an endowment. They don't want to spend it today. They want the center to survive in the longer term, and therefore they support the endowment. The system of insurance, and in Holland I learned a whole lot about that. They're supporting the idea of starting an insurance. And you can go to people and say, we're starting an insurance, but we have no money. Say, no, okay, don't worry. We'll pay 80%, but you pay like 10, 15% for the insurance, not to the center initially, because you need to gain the confidence of the population. And if you start saying we're running a private system, they will run a mile, obviously, for obvious reasons. But insurance and the system in Holland was really good, because they said they will give grants not for the sustainable effort, but for an insurance related to the people, and they will pay 80% so long as the people know that they have to pay 20%. It cannot start immediately, but one has to think about that they have to take over and 10 to 20% at the beginning, insurance, but later as they start growing and they see the influence of, the effect, then they will take over 50, 70, 100%. The government should know that eventually they will take over. The Minister of Health in Ethiopia says that he promises faithfully that he will support through an insurance, because he knows from the World Bank he can get, but the World Bank will not give him a loan for cardiac surgery. It's still perceived an expensive treatment, but he promises that this will be on the agenda in the future. So you have to start the dialogue. So what is a dedicated cardiac center I mentioned? It's obvious, a humanitarian center of excellence, and it should have very clearly defined goals. And the first and most important, almost, to my way of thinking, it should be available to everybody, regardless of color, religion, creed, tribe. You say, we are all the same. And we have to demonstrate that clearly. And I don't have to remind you with what's happening in the Middle East now, with people getting tribal religion in the way. So a cardiac center should be an example for all to see that there is no discrimination and it's available for everybody. We actually sometimes would say that we accept some of the rich people and we don't discriminate against them so long as they demonstrate that only this center can help them. We obviously, the center obviously should give preference to the poor, the desolate, those with complex congenital or other heart disease, and that should be obvious to all, because that's essential to gain the confidence of the community. It should be free of charge at entry. Now, many people say that's not practical and that's not conducive for sustainability. My point in that is that if you are starting and you want the population to own it in the longer run and they can't afford it, you have to show them clearly that it is free of charge at entry. I always give the example of the National Health. People like to stab at the National Health, but I think it's one of the best systems in the world, which actually is a unifying force in the UK. And it's great because patient can walk in and demand the best treatment, and you don't have to say, where is your credit card? It really is important for both the patient, but also for the physicians who can practice medicine at the highest level without thinking of all what goes on with commercialism. The highest standards are really important because not anything goes. It's better than nothing. That cannot be. You have to have systems of audit, and there are many examples. The journal, which I have just shown you, talks about many examples where Magdi, for example, with his near misses, there are other audit systems which talk about, if you would see it in the journal, audit improves outcome. So we have to say, if we want good outcome, we really have to audit ourselves. And we have big brains like Magdi to guide this effort of finding out not how the surgeon performs, that ego trip, but how the center, as he always says, performs. And always inject this idea of partnership in the center, and that can be relatively easily injected into the system if you're starting out from the very beginning, from bottom up, as they say. Training nurses, physicians, and technicians, because we have observed, for example, that nurses and technicians are forgotten, and they're treated very badly, and then everybody blames them. So they are professionals, they have to be respected, they have to be trained, and my God, they perform very, very well if you do that. And the same with technicians. I talked already about how important integrating research and saying it is not a luxury. Now, I will end my talk because I don't want to keep you here forever, by just showing a few examples, and there are a few examples. There are others around the world. There are centers in Guatemala where Aldo Castaneda has really shown the way, if you like. There are centers by La Chaîne de l'Espoir and Bambino Cardiopathico all over the world, in Cameroon, in Southeast Asia. But I would just show you examples from the Chain of Hope UK, which is separate from the La Chaîne de l'Espoir, which is in Paris, but we are sister charities. And the activities are in 7 countries, as you see: Aswan, Addis, Kampala. Bujumbura is a very interesting thing, which is evolving, Maputo. I will just end my talk to show you what's happening in Aswan, just as an example. And this is Aswan. It is right at the tip, or at the southernmost part of Egypt. And it's a neglected area, but at the same time it's very, very beautiful. Some people say it is a cause for tourism. It has tourism, but has ancient Egyptian culture as well. And the Nubians are wonderful people who've been there for over 10,000 years, we're told. And this is the center. It started by leasing part of the General Hospital and then building a purpose-built pediatric unit. And that is the design of the intensive care unit, which was designed by an Italian architect in the form of a flower, and each bed is part of the flower. It's already within like a few weeks of opening the new intensive care for pediatrics. It was completely, as you can see, populated and working. And the workload has also started to increase dramatically. I mean, the hospital opened in 2011. Year 1, I'm talking about open heart surgery now, there were 323 operations. The following year, 480, and went up. And we're expecting to perform 900 this year. We think a ceiling of 1,000 is the limit before having to go to another hospital. But that's on the cards as well. It's not only cardiac surgery, because people think, is it only surgery? No, no, no. Cardiac catheterization, both diagnostic and interventional. These are the numbers. It's now more than 1,500 procedures per year, all for free for the poor and the desolate. I didn't mention that Aswan was chosen also, apart from the reasons I mentioned, because it's gateway to Africa. and many African patients and doctors come for training there. It's near, and it's easier to accommodate them than to have them in the UK or the US or Holland or Germany. There is a program of collaboration between different hospitals in the UK as well as in Germany. And Martin, there is collaboration with the center in Leipzig, where some children come from Africa to be treated there for free. But let's go back to Aswan. Importantly, the administrative group have been supplying us with excellent information about cost effectiveness, because that is the bottom line. The money is scarce, and it's collected money. It doesn't belong to us, and we spend something like $7 million a year, and it's mainly from the poor people, from people now when they see that there is a service at this level. You have donations for $3, $5, $10, and it adds up to 10 million, supporting everything in the center. How to spend this is a massive responsibility, and the administration supplies us with the average cost per patient, and because they show us that it can be very high, we start getting it. That's just the incidentals, if you like, and we can cut it down dramatically so we can treat more patients, and that's really important. The research center, which I'm extremely excited about, because part of the center, there's a whole floor for research where we have sequencers, biomarkers, genetics, tissue engineering, IPS, generated, because there is a fair amount of human material coming out, particularly from a program of inherited heart muscle disease, with people thought that hypertrophic cardiomyopathy, inherited heart muscle disease, was rare, and they hardly see it. We have 800 patients on the national program. Half of them have already been sequenced by next generation sequencing, and we're finding incredible results. And we're learning a lot about, Jane was talking about the difference between sexes, for example, in the incidence of disease. Now we're finding a lot of differences between ethnic origins. What's observed all over the world is different, and there are differences within the same country, which have important bearing on treatment. So it's all very exciting, and that's the research center, which is totally dedicated research center. And this is the staff, which have grown. What is the current figure? 140?
140 with everyone.
Yeah. Zaina is, you can see her in the picture, sitting down there. She's sitting down here again. 140. And that's almost hard to believe that all this happened in 4 years. Well, 4 years in the evolution of centers is small. I have to end the talk by saying that this is just a drop in the ocean. But is it significant? I think it is, because it is hoped that it stimulates other people. You can have a chain reaction which can have an effect on this incredible problem we are facing around the world, cardiovascular disease in low and middle income countries, which is causing massive amount of suffering, but not only suffering, death in young people. Thank you. If they want to.
Do you want questions? Do you have questions, burning questions? It's a pity really to end such an inspiring talk with just eating. Please, yes.
Thank you, Professor Yacoub, for this.
Go to the microphone, please, because you might be saying something important.
Thank you very much, of course, for this lecture. And I'd like to say that I myself have been involved in trying to do some of these things in South America from where I'm based in Canada. And we are at a certain way with our efforts. But one of the things I was wondering, and the question I had about the presentation, was in the first year, how did you, the personnel, how did you put them together? You had an immediate start, it seems. You know, but you had the center, and you leased that part of the hospital. How, like, my problem is, how do you get all these people immediately? What was the strategy?
Excellent question, thank you. I think the word immediately is an exaggeration on my part, and that it is 4 years and it all was magic. It was not. There has been planning for, Ismail, how long? 25 years? We've been going and looking and talking to people and finding a piece of land, and then there were a few people, Ismail, one of them, other people going. Dr. Schoof has been there. So there is a whole lot of pushing at the beginning, but it didn't start until as a hospital dedicated, because I was talking about a dedicated cardiac center, and the same we're trying to do in Jamaica. We have another one in Ethiopia and the one in Burundi. Complete. Having a wing in a general hospital just doesn't work. We've done that, they have intensive care, a few, and they get populated by something else, the standards are gone, and so the concept of a dedicated hospital only started 4 years ago. But before that, we've been going for like 25 years.
Yeah, well, I've been busy with it for about 6 years, and I'm at a stage where I just got the land. So I tried the hospital, things break down, they don't get done, and it's very difficult to do it there. But I've just been granted the land by the government, by one government.
Yeah, I think it's, without going into details, if you get people behind you, like you have said, the young people, we have found really identified a whole lot of young, enthusiastic people. Sometimes we made mistakes, and you get some people who are not team players. Then we say thank you, but thank you, you can go somewhere else. And so invest in people as well as in land and hospital and so on. But what's your point? Sorry.
My point is, did you have to pay them? Like, the problem I have is that if I would recruit or get a young person locally interested.
Yeah, you have to start by a correspondent. Yeah.
Yes, they demand to be paid extra or to be paid better than the local people. So
thank you. All right, I know where you're coming from. So when we start, it is a poor country, wherever you are. But the first correspondents usually they are volunteers because they want to do something. But when you actually start the effort, then you have to specify that people will have to be 100% on the job. Obviously, the young people have families and they're professionals, so you have to pay them to compensate them for that, maybe 2-3 times what the government is paying them, which is absolutely nothing, and to justify why they should not do private practice. So you have to pay them. and say you're dedicated, and they love it because they want to progress academically, professionally, and ideologically to help the people. But before that, they have to survive, and they were fighting for survival rather than serving people. But if you inject that into them, my God, they go like, whoa.
Yes.
Magdi, thank you very much for this presentation. I think you have been and are very inspiring with your work. It's really amazing what you are building up there. It's amazing again and again. What I found really striking is that you mentioned that the funding of this enterprise you have been showing was mainly or fully done by micro donations, like $5 and things like that. Is that really doable in such situations, that you can fund it by donations from the local population?
Well, it has been, but absolutely, you're absolutely right, Simon. We talked about it yesterday. We're very worried because it's a massive commitment, and our people who are helping us with the administration saying we have to say, well, make sure that this will go on, because even during the instability in Egypt, when there was massive instability and revolution, and many people said, you have to stop. And I said, well, if we stop, we'll never start again. So we have to keep going. And keeping going was our biggest savior, because people became more and more generous, and they see that we treat everybody equally. And during Ramadan, when people are donating, they started showering the place with small donation. Your question is apt. Is that going to continue? I don't know, and I'm extremely worried. And the answer is to have the endowment, which guarantees sustainability. Now we're told the endowment for this center is $280 million. There are some people who think that is achievable, but you're right, it's a tall order. But that is probably the most important thing for sustainability, because you can still rely on the people, but you cannot rely on the people forever, because they'll get tired, even from the small donation.
I think, Magdi, you have inspired us really to do what we believe in. And I would like to ask you, when you were young, in the beauty of Aswan, is this one of your dreams?
I wouldn't say that. I actually lived in Aswan for 1 year as a young 10-year-old. I was inspired by the place, and all what I could think about at that time, I must come back here. I didn't think that deep, but as time went by, I saw more and more suffering, and I don't want to give you details, but as a young intern in Cairo University, I used to talk to 8-year-olds in pulmonary edema just to keep their attention, give them rubbish, and watch them die. And that really affected me. I said, this is a mechanical thing, other people are treating it, and we're just watching kids die. That, when I started thinking, maybe there is a solution.
So, no, I think that on that, we should thank Magdi very much for a great deal. I mean, even I feel inspired, having had many inspiratory talks with Magdi. I feel that we go and we have to do what he said, very important. It's not charity, it's duty to help. And I think he has achieved this in a very remarkable way, making it look simple, which it is not. And of course you have to start with money at the beginning. It can't start because you have a dream. And I think we should all go away and think there is something to be done, and it is possible to be done. And we thank Magdi for doing so much. Thank you.